Wonderful. Thank you, Lisa. Hello, everybody. My name is Lizzie Phipps-Druitt, and I'm the Associate Director of Alumni and Supporter Relations at UCL. I just wanted to take a moment to welcome you all to this session today, and thank you so much for giving us your time. This has been the most popular session that we've run at the UCL Connect programme, which I think says a huge amount about the content of this programme, and we are so delighted that so many of you have found it relevant. So thank you so much for coming. We hope to be bringing forward even more of that relevant content to you, your friends, family. So please do keep an eye out for what's coming next. But for now, thank you again for coming, and I will pass over to our wonderful experts.
Hi, so just wanted to quickly give a little bit of housekeeping before we get started. So thank you so much for that introduction, Lizzie. My name is Lisa Yasamides, and I work alongside Lizzie in the alumni relations team at UCL. I'm very excited for today's event and really looking forward to hearing from our guest speakers today. So for those of you who are new to the UCL Connect series, this event is part of the series which looks at improving professional and personal development skills and expertise. And that's for alumni, students, staff across the global UCL community. So whatever stage of life you're in, the UCL Connect series has something for everyone. On the screen are examples of a few of the previous sessions we've run. If you'd like to rewatch any of these sessions, please do follow the URL listed at the bottom of the screen. And as you can see, the program is a mixture of virtual and in-person events, and they run around once a month during term times. So before we begin, I just wanted to let everyone know this event is being recorded and there will be an opportunity to ask some questions to the panel. You can do this by writing your questions in the Q&A section, which you should see at the bottom of your screen. So please put your questions in here at any point during the session and we will come to them at the end. As Lizzie mentioned, this event is our most popular event to date. We've got over 300 people on the call at the moment, so we're not going to have the chance to answer everybody's questions. So if it's really important you upvote the questions you're most keen to be answered, as that was how we'll decide which questions are answered first. If for anybody who would like live captions on their screen, these need to be individually turned on. To use this feature, you will see a button that has 3 dots and the word more at the bottom of your screen. If you click that button and then the word captions, followed by the option that says show captions, that feature will be enabled for you. So up on the screen is what to expect from today's session. We will begin with some brief introductions, followed by the panel discussion and wrapping up with an opportunity for you to ask our panel a question. So with no further ado, I'm delighted to welcome today's speaker, and I'll hand over to our chair, Professor Joyce Harper. Thank you so much.
Thank you, Lisa, and thank you all your team for the fantastic organisation of this event, and welcome everybody. We do aim to have a really wonderful and informative session over the next hour. So please feel free to add those questions to the Q&A. So I'm Professor Joyce Harper. I've been working in reproductive science for almost 40 years and especially been interested in menopause for about the last 10 years and done lots of research on this. And with my colleagues, Shima Tarek, Nikki Kay and others, we feel we have the need now to develop a UK menopause education and support program, which we've called In Tune, which I may tell you more about at the end, but please watch this space. There's lots of things happening there. But without further ado, I'm now going to hand over to all of my panel to just do a brief introduction before we get into the questions. So starting with Olivia.
Hi there, my name is Dr. Olivia Hum. I'm a GP, so I'm an NHS GP in Sussex in England. I'm also a British Menopause Society accredited menopause specialist, and I'm on the National Council of the British Menopause Society. I spend most of my week seeing patients with menopause. I run a private menopause service called Minor Health, and we also do corporate education, so a lot of looking at how menopause affects women at work.
Thank you, Olivia. And Amy.
Hi, I'm Amy Spector. I'm a UCL alum. I did my PhD and my clinical psychology training here, but I've also worked here for nearly 18 years. I'm a professor of the psychology of aging, and in the last couple of years, I've been doing a lot of research on menopause, particularly the link with brain health and psychological symptoms. And I run something called the Menopause Mind Lab at UCL. Thank you.
Thank you, Amy. And Itunu.
Hi, I'm Dr. Tunu Johnson-Shogerton. I also went to UCL, finished in 2011 with my medical degree. I'm a GP and a women's health and menopause specialist, also a BMS accredited menopause specialist. I work in both the NHS and the private sector. I also have a passion about health equity in menopause, and I have a special interest in menopause and how it affects women from different ethnic backgrounds.
Thank you, Ritunu. What a fantastic panel we have today. So I'm going to start with Olivia. Olivia, what is menopause, perimenopause and postmenopause? And what are the key symptoms that women need to look out for?
So there's a lot of confusion about this. And actually in the menopause world, what we tend to talk about is the menopause transition. So the idea, so what happens when we go through puberty is your reproductive system kicks into action. And what it's there for is to try and get you pregnant. So every month in most women, what will happen is that the ovaries will release an egg. And then 2 weeks later, when the egg isn't fertilized, you then have a period. And this is the menstrual cycle. And what happens at menopause is that these eggs stop. Your ovary runs out of eggs and your periods stop. A year after your last period, you are considered as postmenopausal. But what we'll talk about a lot this afternoon is the perimenopause. And the perimenopause it used to be like the year before menopause. It used to be your periods would space out, you start getting symptoms and your periods would stop. But we now realize that perimenopause can start a long time before that. So in my clinic, I'm seeing women in their late 30s and early 40s who are already beginning to get the subtle signs of hormonal change. And what happens really is that your ovaries detect that they're beginning to run out of eggs. And so your body goes into all sorts of hormonal desperate measures to try and get you to ovulate and to get pregnant before it's all finished. And because of that, perimenopause is a time of hormonal transition and of hormonal instability. And it's that instability, and again, especially when we come to talk about the brain, that is what really affects women during that time of their lives, which is also, as we all know, a time when women are working. They've often got children, they might have elderly parents. There's an awful lot going on in their lives. So I think that's why there's been real attention to it. And in terms of symptoms, all we know is that before 5 years ago, all we used to think about was hot flushes. That was the only symptom we talked about. And definitely as a GP, the only women I'd see who would come to me, I maybe saw one a month, would come to me going, oh, I've got some hot flushes, I can't sleep very well because I'm too hot. And we'd say, aha, that's menopause. But now we realise that there are simply a dazzling number of symptoms that we see. And from perimenopause, often they start in that week before your period when your estrogen level is low. We start seeing the mental health side, things like anxiety, low mood, irritability. And then we start the other symptoms as well as the hot flushes. We've got physical symptoms like palpitations, headaches, joint pains. We've got the vulvovaginal symptoms, which we'll talk about later. And then we have the brain symptoms and specifically as well a real impact on sleep. So all the women we see have a different combination of symptoms. Some start early, some never happen at all.
Right, thank you. I think this is the most important thing that people need to understand, because if they just think it's hot flushes and they're getting these other symptoms, then we have the worry. I know lots of women I've talked to, they think they're going mad, they think they're getting dementia, I think they're getting something else wrong with them. So Olivia, why is understanding these symptoms and the menopause so important?
I think it's exactly that. It's because previously, before we were talking about this, women just thought they were going mad. They thought that they couldn't cope anymore. A lot of the women I see in my clinic are in their late 60s. And when they went through it, they often gave up work. And this is when we go in and talk workplaces. You see a lot of women who just thought, I can't cope at work anymore. I've lost my confidence. It must be something to do with me. It's something, I'm not sleeping. I'm really anxious all the time. I can't stand up in front of my lecture theatre and talk anymore. My brain doesn't work. My words aren't coming out. And what we see then is that women who've got so many responsibilities in that time of their lives ended up either just feeling they couldn't do it or withdrawing from it. And again, the impact varies. And what we must be very careful to do is not be too terrifying about menopause, because we need to remember that for about 25% of women, the symptoms will be mild and they won't affect them. And actually, for some women, they feel that it's a liberation. It's the end of contraception. It's a new stage in their lives. So we mustn't sort of portray it as bad. But for about a quarter of women, the symptoms will severely impact their lives just at the time when they really need to be functioning on a day-to-day basis.
Yeah, and we'll talk about this hopefully towards the end, but these symptoms in most women do resolve. They don't last forever, that post-menopause stage that we'll come back to. But I wanted to move on to Amy. So Amy, the psychological effects. So why is psychology relevant to menopause? Isn't it just a medical issue?
Yeah, very good question. Because I think with menopause, we associate it with a hormone change, which Olivia has explained. I think as a psychologist, I'd probably argue that psychology comes into play for any physical symptom or diagnosis. But for menopause, we very much see, I think Olivia has mentioned, sort of psychological symptoms as well. And we see a very close link between the psychological and the physical symptoms. So a couple of examples. Olivia mentioned sleep. We know sleep is very much affected by menopause, and often because people are having really debilitating night sweats. And often for people, hormone therapy, for example, can really help those night sweats. But what people tend to describe is that they've got at that point got into really bad sleep patterns. So that when they wake up with the night sweat, they have these automatic thoughts. And I think probably most of us can relate to this, man or woman, I'm never going to get back to sleep. I'm going to be awake for ages. I'm not going to be able to function tomorrow. And you get into these very kind of repetitive, bad thought cycles. So sometimes we can erase or reduce the physical symptoms, but we've got into these kind of cycles of anxiety that we really need to address as psychological symptoms. Another example is depression. So we know that depression, that menopause, perimenopause particularly, is a period of vulnerability for depression. We did a meta-analysis last year of over 9,000 women, and we found that those in perimenopause had a much higher, significantly higher risk of diagnosis or symptoms of depression than those pre-menopause or post-menopause. And there's a lot of things, an example might be something like body changes, that we see changes in our physical appearance and our distribution of fat, which often leads to low mood, and that low mood leads to comfort eating, for example. So we see these cycles. And as mentioned as well, there's so many pressures on women now, psychologically and socially, that maybe weren't around 20, 30, 40 years ago. So women, we know the average age of menopause is 51. Women are often at the peak of their careers while they still have potentially children who are dependent on them. They might have parents who they need to be looking after. And, in the past, we might have not had so many competing demands. So I think there's very much the psychology side's really important.
Yes, thank you. It's something that we didn't used to really talk about even 5 years ago, definitely not 10 years ago. But I specifically wanted to ask about brain fog. What's brain fog?
Interesting. So brain fog is a term that seems to have emerged. I think I only heard the term brain fog in relation to menopause about 2 years ago, because I certainly had it a lot further back, and no one mentioned brain fog, and it suddenly seems to be absolutely everywhere, doesn't it? I mean, if you look at trying to find a definition of brain fog in menopause, I think that the sort of most widely used definition is difficulty recalling words, numbers, misplacing items, concentration, and forgetfulness. So it describes, certainly for someone who has it, just a feeling of really quite severe forgetfulness, and sometimes you feel quite foggy. And what we do find is that it seems to affect words and sort of verbal learning, verbal memory, more than other cognitive domains. I think what's important to note is that it affects people very differently. Some people won't have any brain fog, but we think about 1 in 10 people really do struggle with it, and this shows up on objective cognitive tests. So it's certainly not something to be dismissed. We think that for most people it tends to get better post menopause. So the hormone fluctuations that we see in perimenopause, we know that neurotransmitters in the brain are very sensitive to these hormones, and this constant kind of peaks and troughs can be quite difficult for the brain. So we think it affects perimenopause the most. And we also know that it's largely subjective. So often as sufferers, I don't like to use the word, but we really feel that we're forgetting stuff, but maybe other people don't notice it as much as us. But I think it's really important. The Menopause Mandate Survey last year, which was a big campaign group, and they got a survey data from nearly 20,000 women in the UK, and they found that brain fog was the most highly reported symptom out of a list of about 15 symptoms. So 76% of people said that they had it. So it's definitely something that we're very aware of, and we know that other data suggests that around 1 in 10 women leave work at this time. So we think there might well be a link between this brain fog and ability to work.
Yeah, we did a survey about 5 years ago, and the clinicians I was working with were quite shocked that the hot flushes were quite low down in symptoms that the women were reporting. It was all the psychological issues that were at the beginning, and that was the first time I think lots of us realised, wow, this really hasn't been reported. But we often hear that women feel that they're getting dementia and that they worry about this, obviously with women getting more dementia than men, and it's something that's very worrying. So how would women know that this isn't early onset dementia?
Yeah, I think our work on brain fog, the research that we're doing, we're finding that that's the most commonly cited fear. And so I think the key things to think about is firstly the nature of the symptoms. So with brain fog and the cognitive problems in menopause, it is largely and almost exclusively around memory and forgetfulness and poor concentration and attention. Dementia is more complex, and you tend to see impairments in other cognitive domains. For example, executive functioning, which involves things like ability to make a cup of tea or get dressed because you're having to follow a sequence of events. Or with dementia, I might look at a phone and it's not that I can't remember the word for a phone, but I don't recognize that it's phone anymore. So it's more complex cognitive problems. The course and progression is very different as well. So generally with dementia, we see, each year that goes by, the symptoms are deteriorating. With brain fog, it tends to remain roughly the same, but perhaps fluctuate throughout the month at different times, or even during the day. But you wouldn't necessarily find that year on year you haven't significantly shown a deterioration, and it shouldn't have an impact on your independent living, but it might well have an impact on your quality of life and general functioning. And the last thing is who notices. So I think with brain fog, we tend to be very critical, and often we notice it more in ourselves. With dementia, sometimes there's a bit of a lack of awareness, and it's often somebody else who spots the problem before the individual. So those are the key things I would think about.
Thank you, Amy. So I can see in the chat there's literally dozens of comments coming in from women talking about their brain fog and how they're feeling. So keep them coming in and keep the discussions going between each other as well. Amy, you mentioned HRT. Can anything be done to improve the psychological symptoms? Will HRT help?
With the symptoms of the brain fog?
Yeah,
I suppose it's, yeah.
and
Absolutely. So, I mean, in terms of treating brain fog and psychological symptoms, HRT can be really helpful. It's often not enough. So we're doing research where we're recruiting people who have both anxiety and depression and brain fog, who feel they need more interventions, and a lot of them are on HRT. So sometimes it's part of the story, but not the full picture. And of course, some people can't take it. But for example, if HRT helps with night sweats, people are likely to sleep better, and that's going to have a positive impact on cognition. I think for brain fog, kind of understanding what it is and knowing it's not dementia, for me certainly was a huge thing, because I thought I had dementia, and as I said, the term brain fog, it wasn't even something we knew about. And this is one of the problems as well. The research on it's really bad, because we didn't even know it was a symptom until recently. It wasn't talked about. So all the studies of menopause where we've looked at interventions and we've rated outcomes, we haven't really accurately measured cognitive functioning, because it just hasn't been a thing that we've been interested in. So understanding it's really helpful. I think cognitive behavioral therapy can be helpful, and other psychological therapies to manage the sort of emotional impact. And also for brain fog, specific cognitive strategies can be helpful. So I think, for example, I find it really hard to remember words, but very easy to remember faces. So I had a meeting with someone called Susanna the other day, and I knew I'd forget her name, but I have a cousin called Susanna, so I was picturing her as I got on the call, and that helped me remember the name. So sometimes just using strategies rather than, but having unrealistic expectations of what you can do, I think is really helpful.
And I saw someone ask, what is HRT? So HRT is hormone replacement therapy. And with menopause, it's mainly the estrogen and progesterone that are the hormones that are involved. So hormone replacement therapy involves estrogen and progesterone and gives that at various doses to the women to hopefully help. But I'm sure we'll talk more about that in a moment. And yeah, as you said, Amy, interesting that I think because we're living such more complex lives and busy lives than our mothers and our grandmothers, this is probably why we didn't really understand these psychological symptoms until relatively recently. But thank goodness we have people like you to help us navigate this. And over to Atunu, how can we adopt a biopsychosocial approach to support women through menopause, particularly in light of the invisible mental load many are carrying at this life stage and in today's society?
Absolutely. So thank you for that question. And for me, as women, we are in 2025 still disproportionately carrying the mental load for society. And that means that we're still doing a lot of the caring responsibilities for society. So that's for the young, the vulnerable, and the elderly, whilst many also working full time, as some of my colleagues have mentioned. But in addition, life has become much more complicated. There's the added mental load of our phones, 24 hours news cycle, social media, and emails 24 hours, being accessible to the whole world all at the same time. And so for a lot of women, it's actually just too much. And if we think about estrogen as a coping mechanism, in the perimenopause, when it becomes unreliable, and in postmenopause, when it's actually gone, for the most part, it can be really, really, really difficult to cope with. And we talked about some of the psychological symptoms that women have. But of course, also, there are other biological things that happen within that sort of midlife age. So there's other health problems that women might have, like thyroid disorders, anemia with heavy periods, because during perimenopause, it's quite common to get irregular heavy periods before the periods eventually stop. But then there's other things as well, vitamin D deficiency, but then also autoimmune conditions, which can be quite common, more common in women. And there's a whole host of other physical health problems, but also the mental health problems, because you can also have coexisting or pre-existing depression or anxiety. So it then becomes really complex because you've got the biological, the estrogen variation that happens in perimenopause, or the estrogen depletion that happens post-menopause. And then you've got other biological factors. You've also got stress, chronic stress causing a problem with the stress hormones. So we talk about the autonomic nervous system, including things like adrenaline, noradrenaline, and then also chronic stress hormones like cortisol. And all of these can have an impact on our female hormones as well. And then in addition, you've got the psychological factors. So you've got the mental load that women are carrying. You've got the psychological symptoms that women are having, and we've talked about some of those. And then you talk about the social factors, in which obviously society is much more fragmented. There's less support for women. So even if women get help with some of the doing now, there's less help with the thinking. We still have to do a lot of the thinking. So it's the woman that needs to think, oh, my daughter has a birthday party. I need to think about the present for the for the little friend. It's the woman that needs to do all of that mostly. I'm not saying that some men do not participate, but generally it falls to the women. So it's all that heavy mental load. And so often when I see women, I'm diagnosing them with perimenopause or menopause and a heavy mental load. And I think both things need to be addressed. So how do we address this? So of course, for most women, the best treatment for the menopausal symptoms is HRT, but some women can't have this, and that's a much more complicated conversation. But in addition, sometimes therapy is needed to unpack some of these issues, but also there's often hidden trauma. And we haven't even mentioned that at all. It's very, very uncommon for a woman to get to 40, 45 and have not experienced some kind of trauma, whether it be domestic abuse, whether it be infertility, whether it be divorce, whether it be all sorts of things that women can go through that cause traumatic issues. And so then you think about psychological, but how do we break down the mental load? So a very incredible occupational therapist taught me about elimination, delegation, and facilitation. And elimination is removing things that we don't need to carry. And we think about rubber balls and glass balls, which is rubber balls, stuff that can bounce away. We don't need to hold on to that because it can come back in 2-3 years. But glass balls are so important. If we drop, they shatter, and that includes our health. So again, it's a very complicated approach. And I always have a biopsychosocial approach in my menopause consultations, because this is not just simply a case of sticking a plaster on with HRT. We need to look at the individual woman, think about her social context, her psychological context, and then provide treatment.
I'm totally agreeing with you. I think we're sometimes just treating it with the HRT and not looking at the root cause. So thank you for that brilliant answer. And we've talked about the hot flushes and night sweats. We've talked about the psychological symptoms, but we haven't yet. Olivia mentioned it, but can we, Itunu, can we have a discussion about the genitourinary health and sexual dysfunction in menopause, which I think is something that's very under discussed and very, very important. It can affect women's quality of life as well as their life with their sex life with their partner. So can you tell us about how that happens during perimenopause?
Absolutely. And one thing that I even want to start this conversation with is almost all of the systemic, which is the symptoms that affect all our body, our brain, almost all of those symptoms get better with time for most women. But the genitourinary syndrome of the menopause, that's the symptoms that affect sort of vaginal dryness, pain with intercourse, urinary symptoms, accidents, so urinary incontinence. Those symptoms, unfortunately, do not get better in the same way and often get worse with time. So it's absolutely vital that these things are identified and treated. And of course, it can have huge impact on relationships. So a lot of perimenopausal and menopausal women don't even want to have sex. And the honest truth is because it's painful, it's uncomfortable, and they haven't spoken about it to anyone. And often, if you don't ask during a consultation, they won't even mention. But also the accidents, women have urinary incontinence. I think of the number of women who, when I've asked them that question, they feel so relieved that they can actually share how impactful it is. And people talk about, feeling embarrassed at work or in social functions. Some people talk about not even wanting to drink when they go out because they're worried. Some people talk about also just the impact it's having on their functionality as women, as vibrant women, and making them feel less like themselves. So these symptoms are treatable. They are treatable. There's vaginal estrogen that can help, and that's actually usable for most women, including many women who've had breast cancer. So actually, this is one treatment that can be used very, very widely. There are non-hormonal treatments as well. For women who can't use vaginal treatments, there's tablets for some women that, because if they're elderly and it's logistically more difficult. So in this particular space, we have so many options. We advise about vaginal moisturizing and lubricants. As I like to say, the vagina likes to be moisturized, just like the vulva likes to be moisturized, just like any place in the body. And so it's so important that we have these conversations and that we are empowering women to take ownership of their own sexuality as we enter into the menopause, because it's really important. I want to see women living their most vibrant and sexual lives, and also having a good control of their genitourinary lives as well.
Thank you. So we've discussed the three main groups of symptoms that we see in perimenopause. And for some, I can see some questions coming in about, do these continue? And for some, unluckily, they do. And we have touched on some of the treatments. So we've talked about hormone therapy. I'm sure some questions will come up on that. And Amy, you mentioned cognitive behavioral therapy. And Itunu, you've mentioned vaginal estrogen. I can see some questions about other treatments coming up. That there are some new drugs being developed, but also our lifestyle is so important at this stage. I can see everyone nodding, and it's something that I think we don't talk about enough. Something I'm very, very passionate about. I'm always talking about how important this is, and not just for the perimenopause, but also to reduce our risk of other chronic health conditions that will start kicking in as we age. We are all aging. So I just want to open this to everybody. Is there anything else you'd like to say about different types of treatments and about lifestyle? We'll start with Olivia.
Yeah, so one other thing that happens, so when you go through the menopause, when you have your last period, your estrogen level drops. And unless you take HRT, you will remain with that low estrogen level for the rest of your life. Now, that has impact on the bones and on the density of your bones, and that also has impact on your heart and your cardiovascular system. So exactly as you were just saying, we need to think about this as a turning point for women's health. And as someone who's recently turned 50, I think you do also start thinking, gosh, I'm entering this next stage of my life. I need to start thinking about optimizing my health. So although we know, and I'm sorry that there are obviously people from abroad here who do HRT, hormone replacement therapy, involves replacing the estrogen that you have lost after menopause. And you often, if you have a womb, then need to take an artificial progestogen or natural progesterone to protect your womb. So that's the basics of it. We know that taking HRT will delay the drop in bone density that happens after menopause. We know that HRT will also delay the changes to the heart and to the cardiovascular system. That's not the only reason to take HRT, and you can do these things without taking HRT. So it's about nutrition, it's about exercise. I always say to the women that I see is that if there is one thing that they could do to change their lifestyle, it would be to do more exercise. And there's just so much evidence about that, not only about cardiovascular exercise, but also the big thing now is about strength and resistance training. And the NHS has got this, sort of says, ideally in women who clearly do nothing else with their time, is half an hour of cardiovascular exercise 5 times a week and 2 sessions of strength and resistance training. Brilliant if you can fit that in. But even if you can get off the bus or stop earlier and walk a little bit more to work, we lead in these immensely sedentary lives in most Western countries. Anything we can do to make ourselves less sedentary is going to optimize our health for the future.
I'm ticking the box, Olivia. I have just done body attack and body pump this morning. So I'm shining my halo, everyone. I'm leading by example. But as you say, not everyone needs HRT. But can I ask Amy, because there's a lot of discussion, I see this on social media all the time by certain people who say that taking HRT will reduce or prevent dementia. So is that true? I know I have my own view, but I'd love to hear what Amy says.
So actually, I'm doing some work at the moment for the World Health Organization, reviewing all the HRT trial data. I would say, I mean, it's I try to remain neutral on this topic, but I don't think there's any evidence that it reduces dementia risk. I think that's the conclusion, or that it increases dementia risk. There are lots of problems with the studies, though. So it doesn't mean that that's a definite answer, but just that we haven't really got the research data. But no, I think there's no evidence to suggest that you should take HRT to reduce dementia risk. I wouldn't recommend it for that reason.
Thank you. That's the exact answer that I would have given as well. So
Okay.
brilliant that I have read, not in the detail you're reading, but I have looked at all the clinical trials to date. But we have many, many people in this space saying that every woman needs to take HRT till the day she dies. And if she doesn't, she'll deteriorate rapidly. So yeah, I wanted to come back to Itunu. So we're very aware that there are differences, we're very aware, but I don't know if the public are, that there are differences in the menopause experience and the impact of menopause on women from different ethnic backgrounds. So can you tell us about this? Why is this culturally competent care so important in this space?
I think it's really important to understand that here in the UK, for Caucasian women, the average age for menopause is around the age of 51. We know that from women of different ethnic backgrounds, that's actually quite different. For example, women from a South Asian background, so that's India, Pakistan, Bangladesh, and that part of the world, the average age is actually around 46. For Black women, so women from Africa and from the Caribbean, the average age is sort of 48, 49, depending on what evidence that you're looking at. And so basically, we know that there are ethnic differences. But what we don't know is how that impacts some of these complications. What we do know is that Black women are more likely to have hypertension early. We also know that Black women are more likely to have higher risks of strokes and other complications. Southeast Asian women are more likely to have diabetes, so 6 times more likely to have diabetes, also more likely to have heart disease. Now, what we know is that when we're thinking around the care of women from ethnic minority backgrounds, we have to take some of these things into consideration. It's not a one-size-fits-all approach. Plus, within a lot of these communities, there's a lot of myths and misconceptions around menopause. You know, I've had women say to me, oh, menopause is not for Black women. You know, what are you talking about? I've literally had women say that to me. And similarly with South Asian women and South Asian colleagues. And so how are we having these conversations? Because many women have, understandably, when they come from communities of color, a mistrust of Western medicine and Western understanding. So some of these things have a lot of stigma in terms of periods, menopause within different communities. In some languages, there isn't even the word for menopause. And so therefore, it can be a very difficult conversation because some women, and I've actually had this, patients who, as soon as their husbands find out that they're menopausal, they actually go and marry a second wife. Or in some African cultures, it's actually that serious. And it can also happen in some South Asian communities. So some women are kind of taken away from this role as a woman and kind of elevated into this sort of ancient role, and they're not ready for that. So again, there's so many different cultural factors that can influence how a woman sees menopause when she comes from a cultural background. So the thing is, it's really important to understand where a woman comes from. And we have to also remember that culture is not a monolith. Just because someone comes from a particular background, there's so many different factors that can shape their own personal experience. So, you know, someone's just said about misogyny. So there is a lot of misogyny that has been many women's experience. There's so many paternalistic cultures that aim to silence women and also make it difficult for women to actually talk about some of these issues. So what is a culturally competent approach? Again, you always have to come back to the biopsychosocial. And as Professor Harper was talking about, the lifestyle factors is so important, particularly for women of color, because we already talked about a lot of the risks that already exist in these communities regarding heart disease, strokes, hypertension, diabetes, many of the things which are worsened by in the postmenopausal period. And of course, there's the genitourinary syndrome of the menopause as well. Again, hush, but can really affect relationships and women in that in those communities. So we have to have the biopsychosocial approach. So there's the lifestyle factors. So really finding out how do we communicate. I always use the word moving more. So I talk about different types of movement, including sort of resistance movement, but I try and put the burden so that it's something that's accessible to women. But then there's also, what are we eating? Cultural food is not necessarily bad. We can't be telling everybody to eat Mediterranean food. That is not their food, right? So we need to be saying, how can we make your food, the food that you enjoy, healthy for your body? And that's working in partnership with patients to understand their own context. But then, of course, there's the mental load, which can be even more heightened for women of color, because often, you know, they're living in multi-generational households. There is the, you might have heard about this, the immigrant tax. So many people of color have to not only support their own families locally, but also have to support families in multiple countries abroad. So some people are the lifeline for all their brothers and sisters and their brothers and sisters' children and the multi-generations in different countries. So this is the pressure that many women of color understand. So we need to talk about mental load management. We need to talk about social networks. So sometimes being in a country that's not your own and being an immigrant, you can be isolated. So thinking about how can we make sure that people are isolated. And there's also religion, making sure that we respect people's faith. Some of the treatments that we have are not necessarily halal, or, you know, and you have to then try and find options that would match people's religious faith. So there's the biopsychosocial, so looking at the different biological factors. There's the psychology, because I've talked about some of the stigma and things that are associated, so that adds to the extra factors. And then, of course, there's the social. So I think it's really important, and I do quite a lot of work, and I know some of you as well, going into the community, grassroots, actually having conversations that are specifically directed at local communities. I've written a booklet, a personal guide to menopause for Black women, that I wrote to try and empower women to have those conversations. With information specifically written with them in mind. So again, we need to take it to the grassroots. We need to empower clinicians to provide this culturally competent approach.
Thank you. Thank you. And we have a paper coming out very soon where we surveyed specifically Black women to ask them how they felt about menopause. And they, as you said, they have some specific aims and needs that we need to address. And our panel have talked about the average age women in different cultures go through menopause. But just to say that even for Caucasian women, when we talk about age 51, that's an average. So 45 to 55 is totally normal. But I often hear women say, oh, I went through an early menopause. My period stopped when I was 47 or 48. But just to stress, that's not young. That's totally within the normal range. And I must say, we're going to move to the Q&A now. We've got some fantastic questions. It's almost as if I wrote them, because the top three are certainly things that I would really like to discuss. So thank you. The top question is, there are a number of supplements on the market that promise the world. What do you recommend for anyone entering their 40s and starting the perimenopause journey? And I can tell you that we are doing a study, a very in-depth study at the moment on, we're looking at about 200 menopause supplements with the University of Oxford, with my MSc student Poppy. And I can't wait to share the data, but I'm not going to tell you anything about it now. But I'd like to hear from our panel. What's your view on supplements? Who wants to go first? Olivia.
And this is so interesting. And whenever I do these talks, we always get asked this. And I think what we're hearing from women is that we've gone from a time in which there was literally no information about menopause to a time in which they are just flooded with information. So, you know, you are absolutely targeted every time you open your social media. There's all this like, oh, I took this collagen and my hair was amazing, etc. What we know is there is very little evidence for any of these supplements. Supplements in the UK are not regulated. So what always really surprises women is that they can make any claims they want on their advertising. They're not in any way regulated. They don't have to undergo the sort of double-blind randomized controlled trials that drugs do. They can literally say anything. And they also know that the placebo effect of any of these things is massive, because of course, when you're feeling awful in your 40s and you're really struggling and you're feeling terrible, and someone gives you this beautiful thing that someone else took and it made them feel great, of course that's going to make you feel good, and that's natural. What we see in the medical world is that the only supplement that we can recommend is vitamin D. Vitamin D, there is evidence that this is good for your bone health, and especially in the UK, in between October and April, the sun is not strong enough for us to be able to metabolize vitamin D in our skin. So that is the one thing. Everything else we would rather that people got through diet, and that is through eating a healthy, balanced diet involving sort of fruit, vegetables, etc. So that the other things that are sometimes marketed in the supplements are things called phytoestrogens, and these are plant estrogens. There is some weak evidence for some of these, but only for vasomotor symptoms, so for hot flushes and night sweats, and those are things like soy and the extracts and the red clover, back cohosh, that kind of thing. So, and again, I'd be really excited, Joyce, to read the review article. If anyone is interested, the North American Menopause Society have done a fantastic summary of all the evidence of non-hormonal alternatives to HRT, and it has the evidence of everything, including things like reflexology and roots of this, that, and the other. And so that, at the moment, is the sort of definitive document. If you want to look through, find your supplement and see sort of what evidence is in there.
Olivia, if you have the link for that, could you possibly put it in the chat?
Yeah, that would
be really brilliant. Yeah, and my advice: save your money. They're very heavily marketed on testimonials and not on science. But let's move to the next question, which again, perfect. But this comes up so much and it's come up in my interviews with women. Why does perimenopause seem to uncover previously masked neurodivergent traits? So we're seeing a lot of women who, I don't know whether, I'd like to hear what you think. Are they just realizing during the perimenopause that they are neurodivergent, or was it always there, or has it come up? What's going on? Maybe Amy might know something for that.
Yeah, absolutely. So we've got a number of projects on this at the moment. There's very little known, but lots of anecdotal evidence that, for example, a lot more women are being diagnosed with ADHD. That seems to be the really common diagnosis, but also lots of people across the age range and men are also having increased diagnoses of ADHD. So we're not quite sure whether it's significantly higher, but I think the definition of ADHD and brain fog is quite similar, because a lot of it's about attention and concentration. And so my theory is that maybe that's sort of been masked somehow, because remember with all neurodiversity, it's on a spectrum, and we can function with some level of neurodiversity very well often, and often you don't need a diagnosis, and we just learn to live with the way that our brain works. But sometimes when our concentration or attention gets that little bit worse and we're not sleeping and there are all these other things happening, maybe we're sort of tipped slightly to that point where it uncovers something that was always there. So I think probably gut feeling is maybe it was always there, but the symptoms, we know that we say it's a kind of period of vulnerability to most mental health conditions, where we're more likely to get a diagnosis of things because we become more vulnerable because of all the sort of biopsychosocial pressures, that actually that's probably the reason, rather than people suddenly developing symptoms of neurodiversity from scratch.
Yeah, I think that comes up with so many other issues that women may experience at that time. It's been bubbling under, but it certainly brings it to the surface. Let's go back to hot flushes. There's a question here that I would love some ideas of how to approach them, both physically and psychologically. So we've talked about HRT, we've talked about CBT. Are there any ways that women can deal with the hot flushes, or hot flashes, depending where you come from? Anyone got any thoughts on that? Brilliant. I was going to ask you.
That's fine. So I actually think this is really important because, 80% of perimenopausal and menopausal women will suffer from hot flushes. So it's one of the symptoms, and it's one of the symptoms that causes a lot of fear, because people are like, I'm sweating during meetings at work. People feel so conscious of it. However, as I say, treatment in terms of HRT can be really helpful. There are non-hormonal treatment options as well for women that can't have HRT. And there's new one called fezolinetant. Where I say new, it's been around for about a year. Veoza is the brand name. And there's a new one, which is a similar drug that has literally just come out as well, which is in the same family. So the NK1 and the new one is the NK1 and 3 receptor antagonist. I might have got that the wrong way around. But at the end of the day, there are new drugs that are there that are non-hormonal. There's also the older drugs that we have. So we've got things like oxybutynin, clonidine, gabapentin, pregabalin, antidepressants. So some antidepressants can be used in the management of hot flushes. So that includes things like venlafaxine, sertraline, fluoxetine, all the standard antidepressants. And so there's a whole host of things that can be used. But on the whole, as we say, if you can have HRT generally tends to be the best, but it doesn't work for everyone, and we have to be mindful of that. But what are the other options? One of the things is I actually did some early training in CBT for hot flushes, which is really important. So there's lifestyle factors. So, it doesn't hurt to carry a small hand fan around with you as needed. Wearing the kind of materials that are helpful, and you can find some nice cotton clothing, especially during the summer, sheets that are helpful, especially for people who have night sweats. All of that is important, but your psychological framing is also crucial. So I'll give you an example of two people are at a party and suddenly a hot flush starts to feel like it's coming on. The first one is, I have to leave. Oh my God, everyone's looking at me. Oh gosh, it's a hot flush. And then the hot flush then gets even worse because you're agitated and you're stressed. And they end their evening, they have to go home. Maybe they drag their partner, ruining his night as well. And it's, you know, it's messed up. Now, of course, I know that for a lot of women, you know, it's quite distressing. So I'm not minimizing the distress, but I'm talking about another approach. Okay, I'm having a hot flush. It is what it is what it is. Okay. Okay, maybe I'm going to avoid that second glass of wine because it's going to make it worse. Maybe I'm even going to joke around about it and say, oh, yeah, it's a hot flush. This is what it is. And get on with my evening and actually have a really good time with my friends and family and not leave. So at the end of the day, both women were in exactly the same situation, but the psychological framing and how they perceived it changed their outcome and how they experienced it. So yes, psychological framing and CBT may not necessarily stop the hot flush, but they may reduce its intensity and its impact on your quality of life. So there's other ways of thinking about it as well.
Yeah, yes, brilliant, excellent. And yes, that second glass of wine won't help for sure.
No.
Thinking, you mentioned their partner, thinking about their partner. Now we mustn't laugh at this one, but I've seen a lot of jokes around this on social media. Any recommendations on how we help support heightened irritability in our partner going through their menopause? But I was thinking, I read this slightly around the wrong way, but I think it works. I know a lot of women, they do become very irritable with their partner. I know the joke has been listening to their partner eat. You know, why is he making so much noise eating? You know, so we've got irritability. So how can we help with the heightened irritability that women experience at this stage where everything seems to annoy us? Any thoughts? Maybe Amy or
Yeah, I mean,
Olivia. I don't mind.
I don't think there's a one size fits all answer to this, because we all become irritable for different reasons and we all respond to different things. So I think it's usually, you know, trying to identify patterns and cycles, and you see that in relationships, don't you? That someone does something and the partner responds in a certain way, which just annoys them even more, and you get into these kind of negative cycles quite easily, and that doesn't need to be menopause specific. It can just happen at all times. So I think just trying to understand triggers and trying to look at what is causing the irritability, if there is anything that you can do. But sometimes you know, I think it's also a case of just trying to be a bit kinder to yourself and to others around, and just sometimes let go the things that aren't really important. I really liked Atunu's example before of elimination, and you know, just what is it worth getting irritable about that, and is it worth responding to that, or is it easier just to walk away because you know choosing your battles, I guess.
Yeah, and I think that conversation, having that conversation with your partner, or with each other, to say it's nothing personal. It's just my hormones. It's how I'm feeling. You know, you would get irritated by so many different things, and I do worry about divorces during this time, where I think if we were all a little bit more open and discussed and understood that these things are not personal. Olivia, did you want to add something there
Yeah,
about
and it was exactly to put that point, actually, is that actually, although we sort of go, oh, isn't it funny, the rage, haha, actually, for a lot of women, this is a terrifying symptom. So what women say is that they're sitting there and someone will leave the milk out of the fridge and suddenly they literally go from 0 to 60 in a second. They blow up, and they can see themselves taking this out on their kids and on their partner, because of course, often they can manage to keep it together at work, just about, but it's when they get home that they take it out on the people who are closest to them, and this has a really big impact on their relationship. And a lot of the and again, when we do these talks in workplaces, we really encourage the men to come along as well, because often the men, there's a huge impact on the relationships. The men are watching the person that they love change in personality, become quite unhappy, you know, finding this. And so it is something, and it's exactly what you said, Joyce. It's about keeping the lines of communication open. It's about being able to talk about it, although, as we know, it's sometimes quite difficult to tell someone that they're being irritable and unreasonable, but it can be a really tough time for relationships. And what I say to the men who ask is that learn as much about it as you can, attend things like this, read about it, try and work out what's going through, make your, try and talk about it. Often women as well, is like Ituna was saying with the sex, so often women will retreat from intimacy because they feel that they've changed, they don't like the way that they are anymore, they feel that they've become unattractive, and often it's the men are saying, I still love you, I still find you attractive, but they're just not feeling it. So it's really hard to keep a relationship going during this, but I think, like with anything, it's about communication. And the more you know as a man about what your partner might be going through, the better you are going to be at being able to talk about it. So that's what we would encourage.
And if you're in a household where you've got teenagers going through puberty, and puberty and menopause are very similar stages, we've got hormones roller coastering around in both situations. So I've always said, if we've got kids going through puberty, with mothers going through the perimenopause in the same house, please open those lines of conversation, because it's a very hormonal house. And I did a parenting course when my kids were going through puberty, and the teacher said, if they're having a moment, walk away, just walk away, pick your battles. So having those conversations. Right, we've got a few minutes left. I'm just going to ask one last quick question, which is so important, which is about PMDD. So maybe one of you like to say what PMDD is, but we've had a question when we did our menopause event a few weeks ago, where someone said, do women with PMDD have a worse perimenopause, or do we know anything about that? So, Itunu, did you want to answer that? What is PMDD, and do we know anything about women going through menopause with PMDD? And this will be our last.
PMDD is premenstrual dysphoric disorder, and it's a very severe type of PMS where women will get so things like rage, irritability, but also, and I think importantly, suicidal thoughts. And sometimes women are so depressed during this time that women have been known to lose their lives. So it's a very, very severe version. So the general thing that sort of is noted is that women who have really bad PMS or PMDD, as well as women who have struggled during the postnatal period, are more likely, it's an indication that they may have a more difficult perimenopause. It's not definite, but it's definitely, there's some kind of relationship or understanding, and it's all about sensitivity to hormonal change. That these women are more sensitive to hormonal change, and in particular, the hormone that is most seen in that luteal phase, which is the last 2 weeks of the cycle, is progesterone. And so some of these women are incredibly sensitive to progesterone, and these women will need treatment in terms of PMDD. And women who also have PMS during early perimenopause may notice PMDD-like symptoms as they navigate perimenopause. And it's really important that these things are treated and you see someone who really knows about it. And it's really about trying to see how can we do lifestyle changes. And we already talked about that. Those are fundamental, but also how can we get hormonal treatments that help level out the hormones? And it's very important to consider the progesterone used in these patients, because oftentimes very progestogenic progesterones might make symptoms worse. So we have to be quite cautious in how we treat these patients. We have to make sure that we kind of balance things out. And sometimes we might even need to use some antidepressants. So sometimes we even use antidepressants in something called a luteal phase, which is the last 2 weeks of the cycle. So women are on 2 weeks on, 2 weeks off of the antidepressant to help manage the symptoms as well.
Yeah, certainly that PMS and PMDD can definitely get worse during that perimenopause phase. We are at the end. Thank you so much, everybody, for your amazing questions in the Q&A. There were over 70 questions, and I lost track, hundreds of comments in the chat. And thank you to our amazing and knowledgeable panel, Olivia, Amy, and Itunu, for your brilliant expert advice to everybody. And I'm now going to hand back to Lisa just to close the session, but it's been absolutely fantastic.
Oh, thank you, Joyce, and thank you, Olivia, Amy, and Itunu. This has honestly been just such an insightful session. Like just looking at the chat, the thank you messages from all of our attendees. Thank you to everybody who's joined us today as well. My colleague Emily has shared a QR code on the screen which if you could spare just a few minutes to leave your feedback, it'll be so invaluable for us as we look ahead and plan for next year. We're hoping to kick off next year's Connect event sessions with a session on memory and cognitive function. So I will hopefully be in touch when I send out the recording with more details on that next week. So all that leaves me to say now is, once again, thank you so much to our panel. Thank you to everyone who's joined us for this session today. We hope you have a wonderful summer, and we look forward to seeing you at a UCL Connect event in the autumn. Thank you so much.